Welcome to today's quiz on ACE inhibitors, a vital class of medications used in managing hypertension, heart failure, and other cardiovascular conditions. This quiz features 10 multiple-choice, scenario-based questions designed to test and strengthen your understanding. Each question includes 5 answer choices, followed by the correct answer and a detailed explanation. For a thorough review of key concepts related to ACE inhibitors, check out the companion video linked in the description. So, let's begin. Question 1. Mr. Harrison, a 57-year-old man with a history of hypertension and type 2 diabetes mellitus, was recently started on lisinopril for blood pressure control. 1 week later, he presents with swelling of the lips and difficulty breathing. He denies any new food allergies and has no history of similar reactions. His vitals are stable, and there is no wheezing on auscultation. He is diagnosed with angioedema. Which of the following is the most appropriate next step in management? Option A, continue lisinopril and add an antihistamine. Option B, discontinue lisinopril and switch to losartan. Option C, prescribe epinephrine and continue ACE inhibitor therapy. Option D, stop lisinopril and initiate amlodipine. Option E, restart lisinopril after resolution of symptoms. The correct answer is option B, discontinue lisinopril and switch to losartan. The explanation is that ACE inhibitors, such as lisinopril, can cause angioedema due to the accumulation of bradykinin, which increases vascular permeability. Once angioedema occurs, the ACE inhibitor must be discontinued permanently, as re-exposure carries a high risk of recurrence. Angiotensin receptor blockers, ARBs, like losartan, are reasonable alternatives because they do not significantly affect bradykinin levels and are less likely to cause angioedema. Antihistamines and epinephrine are not first-line treatments for ACE inhibitor-induced angioedema, as the reaction is not histamine-mediated. Question 2. Mrs. Anderson, a 72-year-old woman with chronic kidney disease, CKD, stage 3, was started on ramipril for hypertension. 1 week later, her blood tests show a serum creatinine increase from 1.2 mg per deciliter to 1.6 mg per deciliter, normal, 0.6 to 1.3 mg DL, and a potassium level of 5.3 millimoles per liter, normal, 3.5 to 5.1 millimoles per liter. She denies symptoms of weakness or palpitations. Which of the following is the most appropriate next step? Option A, continue ramipril and recheck renal function in 2 weeks. Option B, discontinue ramipril and start hydrochlorothiazide. Option C, reduce the dose of ramipril and monitor closely. Option D, discontinue ramipril and switch to spirolactone. Option E, start sodium polystyrene sulfonate and continue ramipril. The correct answer is option C, reduce the dose of ramipril and monitor closely. The explanation is that a mild increase in serum creatinine, up to 30% from baseline, after starting an ACE inhibitor is expected and does not necessitate discontinuation. This occurs due to the reduction in glomerular filtration pressure, which helps preserve long-term kidney function in CKD. Hyperkalemia is a known side effect of ACE inhibitors, and a potassium level of 5.3 millimoles per liter warrants close monitoring but not immediate discontinuation. Switching to hydrochlorothiazide or spirolactone is inappropriate, as these do not provide the same renal and cardiovascular benefits as ACE inhibitors. Question 3. Mr. Thompson, a 65-year-old man with heart failure with reduced ejection fraction, HFrEF, was started on enalapril. He presents to the clinic with persistent dry cough but no signs of respiratory distress. His blood pressure is 125/78 mmHg, and his renal function remains stable. Which of the following is the best alternative for his condition? Option A, losartan. Option B, metoprolol. Option C, amlodipine. Option D, spirolactone. Option E, furosemide. The correct answer is option A, losartan. The explanation is that ACE inhibitors, like enalapril, can cause a persistent dry cough due to increased bradykinin levels. In patients who experience this side effect, an angiotensin receptor blocker, ARB, such as losartan, is the preferred alternative, as it provides similar cardiovascular benefits without affecting bradykinin metabolism. Beta blockers like metoprolol and diuretics such as furosemide are useful in heart failure but do not replace the role of ACE inhibitors or ARBs in improving mortality. Calcium channel blockers like amlodipine are not first line for heart failure with reduced ejection fraction due to their limited effect on disease progression. Question 4. Mr. Garcia, a 63-year-old man with hypertension and a history of myocardial infarction, is prescribed perindopril. Which of the following statements regarding ACE inhibitors is incorrect? Option A, they reduce mortality in heart failure with reduced ejection fraction. Option B, they should be avoided in patients with bilateral renal artery stenosis. Option C, they may cause hyperkalemia due to decreased aldosterone production. Option D, they are the preferred antihypertensive agents in pregnancy. Option E, they inhibit bradykinin breakdown, which may contribute to side effects. The correct answer is option D, they are the preferred antihypertensive agents in pregnancy. The explanation is that ACE inhibitors, including perindopril, are contraindicated in pregnancy due to their teratogenic effects, which can lead to fetal renal dysfunction, oligohydramnios, and developmental abnormalities. Instead, safer antihypertensive alternatives such as methyldopa, labetalol, or nifedipine should be used in pregnancy. The other options are correct. ACE inhibitors reduce mortality in heart failure, should be avoided in bilateral renal artery stenosis due to the risk of acute kidney injury, may cause hyperkalemia by inhibiting aldosterone, and increase bradykinin levels, which contributes to side effects like cough and angioedema. Question 5. Mrs. Robinson, a 30-year-old woman with newly diagnosed essential hypertension, is planning pregnancy and seeks advice regarding her current medication, fasinapril. Which of the following is the most appropriate course of action? Option A, continue fasinapril, as it is safe in early pregnancy. Option B, discontinue fasinapril and switch to methyldopa. Option C, substitute fasinapril with hydrochlorothiazide. Option D, stop fasinapril and initiate spiralactone. Option E, continue fasinapril but monitor fetal development closely. The correct answer is option B, discontinue fasinapril and switch to methyldopa. The explanation is that ACE inhibitors, including fasinapril, are teratogenic and must be discontinued in women planning pregnancy. Methyldopa is a preferred alternative due to its long-established safety profile in pregnancy. Continuing fasinapril with monitoring is not acceptable, as even early exposure increases the risk of fetal harm. Hydrochlorothiazide and spiralactone are not first-line options for pregnant women, as they can have adverse effects on maternal and fetal hemodynamics. Prompt discontinuation of fasinapril and initiation of a safer antihypertensive is the best course of action. Question 6. Mr. Wilson, a 59-year-old man with hypertension and diabetic nephropathy, is prescribed trandolapril. Which of the following drugs is least appropriate to be used concomitantly with trandolapril due to the risk of severe hyperkalemia? Option A, amlodipine. Option B, metformin. Option C, spiralactone. Option D, furosemide. Option E, atorvastatin. The correct answer is option C, spiralactone. The explanation is that trandolapril, an angiotensin-converting enzyme, ACE, inhibitor, can increase serum potassium levels by reducing aldosterone secretion. Spiralactone, a potassium-sparing diuretic, also increases potassium retention. The combination of these two drugs significantly raises the risk of severe hyperkalemia, which can lead to life-threatening arrhythmias. The other options do not have a direct effect on potassium homeostasis. For instance, amlodipine is a calcium channel blocker, and furosemide is a loop diuretic that actually promotes potassium excretion. Question 7. Mrs. Evans, a 48-year-old woman with chronic hypertension, is prescribed quinapril. She is also taking NSAIDs regularly for osteoarthritis. What is the primary concern regarding this combination? Option A, increased risk of gastrointestinal bleeding. Option B, reduced antihypertensive efficacy. Option C, increased risk of hypokalemia. Option D, bradycardia and hypertension. Option E, QT prolongation. The correct answer is option B, reduced antihypertensive efficacy. The explanation is that NSAIDs can impair the antihypertensive effects of ACE inhibitors like quinapril by inhibiting prostaglandin-mediated vasodilation in the kidneys. This can lead to sodium and water retention, resulting in reduced blood pressure control. This interaction is particularly concerning in patients with chronic hypertension or renal impairment. While NSAIDs can increase the risk of gastrointestinal bleeding, this is not the primary concern in this context. Likewise, ACE inhibitors are more commonly associated with hyperkalemia rather than hypokalemia, and they do not typically cause QT prolongation or bradycardia. Question 8. Mr. Parker, a 70-year-old man with heart failure and chronic kidney disease, is prescribed captopril. After 2 months, he develops progressive anemia with a low reticulocyte count and positive Coombs test. What is the most likely mechanism of this adverse effect? Option A, hemolysis due to oxidative stress. Option B, ACE inhibitor-induced aplastic anemia. Option C, bone marrow suppression. Option D, autoimmune hemolytic anemia. Option E, microangiopathic hemolytic anemia. The correct answer is option D, autoimmune hemolytic anemia. The explanation is that ACE inhibitors, particularly captopril, have been associated with drug-induced autoimmune hemolytic anemia, which is confirmed by a positive Coombs test. This occurs due to their development of autoantibodies that target red blood cells, leading to their permatique destruction. Unlike oxidative stress-induced hemolysis, which is common in patients with G6PD deficiency, autoimmune hemolysis is immune-mediated. Aplastic anemia and bone marrow suppression are rare side effects of ACE inhibitors, and microangiopathic hemolytic anemia is typically seen in conditions like thrombotic thrombocytopenic purpura rather than ACE inhibitor use. Question 9. Mr. Miller, a 67-year-old man with hypertension and congestive heart failure, is on enalapril. His doctor is considering increasing the dose. Which of the following factors would be the least important to monitor in this patient? Option A, serum creatinine. Option B, serum potassium. Option C, cough severity. Option D, blood pressure. Option E, heart rate. The correct answer is option E, heart rate. The explanation is that ACE inhibitors like enalapril do not have a direct effect on heart rate, making it the least relevant parameter to monitor when adjusting the dose. However, renal function, potassium levels, and blood pressure must be closely monitored, as enalapril can cause hyperkalemia and worsen kidney function, especially in patients with heart failure. A persistent cough is also a well-known side effect of ACE inhibitors due to increased bradykinin levels. Since enalapril primarily affects vascular tone rather than cardiac conduction, it does not significantly impact heart rate. Question 10. Mrs. Davis, a 75-year-old woman with hypertension and osteoporosis, is started on perindopril. Which of the following is not a known pharmacokinetic feature of ACE inhibitors? Option A, some ACE inhibitors require hepatic activation to active metabolites. Option B, most ACE inhibitors are primarily excreted by the kidneys. Option C, food may reduce the bioavailability of some ACE inhibitors. Option D, ACE inhibitors significantly induce hepatic enzymes. Option E, some ACE inhibitors have longer half-lives, allowing once-daily dosing. The correct answer is option D, ACE inhibitors significantly induce hepatic enzymes. The explanation is that ACE inhibitors do not significantly induce hepatic enzymes, meaning they do not markedly affect the metabolism of other drugs via enzyme induction. While some ACE inhibitors are prodrugs requiring hepatic activation, most are eliminated renally, necessitating dose adjustments in renal impairment. The bioavailability of certain ACE inhibitors, like captopril, may be reduced by food, which is why they are often recommended to be taken on an empty stomach. Additionally, some ACE inhibitors have long half-lives, allowing for convenient once-daily dosing. Conclusion. That wraps up our revision on ACE inhibitors. I hope you found this quiz session engaging and informative. To deepen your knowledge further, consider reading resources like Katzung and Trevor's Clinical Pharmacology, Rang and Dale's Pharmacology, and the British National Formulary, BNF. These references will solidify your understanding and enhance your preparation. Also take note that in this video, Any mention of guidelines will specifically refer to those outlined in the BNF. Thanks for watching. If you found this video helpful, don't forget to give it a thumbs up and share it with others. Subscribe to this channel and hit the notification bell so you never miss an update in the series that we are doing. For more learning resources, check the description below. See you in the next video.